Okay, recording started. So, hi everybody. It's so nice to have you all here again for another week of Road to the PSA. Thank you, everybody, joining us for Women's Health this week. I'm really excited that we have Catherine with us. Catherine has been instrumental in designing this series, so it's great to have her showing her face and teaching, even though she's been behind the scenes designing this series and really helping me out from the med student side. So thank you so much, Catherine. And we've got Moji as well with us, who did psychiatry a couple of weeks ago now. He'll be in the chat, popping in that message for you guys to like when you finish questions and also answering any questions you guys have along the way. So without further ado, Dr. Bowes, please go ahead.
Thank you so much. So as Charlotte said, make use of the chat with as many questions as you want. Let us know if there are any technical issues. If you want us to speed up, slow down, that's absolutely fine. Just please tell us. So this week's session is going to be on women's health. Some key websites that you might want to utilise or need to utilise would be the BNF and Medicines Complete, which are hopefully quite familiar to you now, but there are the QR codes if that's helpful. Just a disclaimer, all this content is purely for educational purposes and it's based off NICE and BNF guidelines, unless I've explicitly stated I've got this from another resource, so that you're aware where all this information came from. In terms of how I've structured this session, so I like to use the PSA blueprint when I was revising. I found that very helpful. And you can find this example table within that blueprint. So we're looking at the obs and gynae column here, and I've tried to at least get one or two example questions from each of these boxes. For me, I use this as sort of a revision checklist when I was revising, and I found it incredibly helpful. So that's my little tip there. So let's just get going. So just an overview of contraception. So we've got our combined hormonal contraceptives. Now, I think most commonly we think these come in tablets, and that is by far most common, but you can also use transdermal patches and vaginal rings. So if these are used perfectly, then their failure rate is less than 1%, but they're highly user dependent, as I'm sure you can imagine. So things to be aware of with the combined pill, I would say, is that weight and drug interactions are particularly important. So if someone has a higher weight, first of all, that might be a contraindication to having the combined pill, but they might also not be suitable for the transdermal route. In terms of interactions, so there are lots of interactions that will make the combined pill less effective, which I will signpost later in the slides. And malabsorption can also affect the efficacy as well. So any malabsorption syndromes, the pill might be less effective. And it should not be continued beyond 50 years of age. So that's quite important. If your question stem, the lady is an older lady, say 56, then you can already discount this one. In terms of contraindications to be aware of, so you're basing this off the UMEC criteria, and unfortunately the BNF doesn't have a wonderful section on contraception. So I would suggest learning these if I were you. So BMI more than 35, women who smoke and are aged more than 35 years, hypertension, stroke or history of stroke, and that will include history of TIA as well, ischemic heart disease, vascular disease, and if someone has multiple risk factors for cardiovascular disease, so I know high lipids, strong family history, then this would be less appropriate. So moving on, you've also got your progesterone-only contraceptives. So once again, they come in multiple different forms. So oral, so your progesterone-only pill, your injectable form, so that's your depot injection, and then subdermal, so that's your progesterone implant that's usually in the upper arm, and intrauterine as well, so that's your intrauterine system with the progesterone, so that's different from device. And once again, the failure rate is pretty low if it's used perfectly, but some forms are going to be far more user dependent than others. So the intrauterine system is not very user dependent, but the oral tablet very much will be. and the depot injection really needs to be given every 12 to 13 weeks. So if you go beyond 14 weeks, then it will become less effective. So that's probably what I'd summarize there. This slide is to try and show you how to utilize the BNF when you're prescribing combined oral contraceptives. Because I think it can be quite complicated. There are lots of different brand names. They contain different amounts of hormones. So I would search the treatment summary contraceptives hormonal, which is in the top right-hand corner of the slide, and you can go from there. So I commonly just learn some brand names. So I've learned Regavidon and Microgynon, so I can just type that in when I'm searching up the drug, and I know it's going to come up with a combined contraceptive pill. So that saved me a lot of time in the exam. Quick sort of practical tip here is that if someone's on combined hormonal contraception, then that will need to be discontinued at least 4 weeks prior to elective surgery, and particularly any sort of major surgery. And so an alternative method of contraception will be required for the duration, and then you can restart it 2 weeks after the patient's fully mobilizing. So that might come up in a prescription review question. If it's a patient about to go in for surgery, that might be appropriate, or even an advice, a counselling question for the patient if they're on the contraceptive pill and they've got a planned surgery coming up. So that's how I think that information might be tested. And if you can't discontinue it, then consider thromboprophylaxis for these patients. Okay, so a little bit more about progesterone-only contraceptives. So we talked about the progesterone-only pill very briefly. We've also got the injection that I mentioned. So for the PSA, I would learn the name of the contraceptive depot. So medroxyprogesterone acetate is the common one that we use in the UK. And then you can just type that in when you're prescribing and saves you a lot of time. So that's given every 12 to 13 weeks, like I said. Things to be aware of is that this would probably be less appropriate in younger patients, and it would likely be last line if they're very young patients, so under 18 years of age. That being because it can cause a small loss of bone mineral density. So you really don't want to be losing that at a younger age, and you need to be reviewing it quite often, because that's definitely a risk of being on this sort of for a prolonged period of time. So that's something to look out for. And when you're counselling patients, it's really important that you are aware that this contraceptive method can have a delay in the return of fertility up to a year, so it's quite significant. So they're sort of key points for those. In terms of the implant, it can be quite effective and it can last for up to 3 years. And then the intrauterine system, that can last from 3 to 10 years, depending on the device that's used. And one thing I would say sort of practically is that a patient must have had a pregnancy test before that's inserted. And depending on their risk factors, it might be appropriate to screen for STIs as well, because with any intrauterine system or device, one of the contraindications to giving that is going to be pelvic inflammatory disease. But with the intrauterine system, it's really good. It can help period pain. It can help with heavy periods, and that is the intrauterine system. The device can actually make heavy periods worse. So lots of benefits. And then the intrauterine device, which I just mentioned. So another contraindication, again, so pelvic inflammatory disease, Wilson's disease, so that's where you have a buildup of copper in the body, so it's not appropriate to give more copper in that intrauterine device. And then with a lot of these contraceptive forms, it's probably inappropriate to prescribe if there's any form of unexplained vaginal bleeding. It could make it worse. This could mask important symptoms that might point to a malignancy. So that's definitely something to bear in mind when you're prescribing contraception, but also hormone replacement therapy as well, also HRT. Perfect. So we'll move on. That's a little whistle-stop tour. Here it's just trying to demonstrate again how to use the BNF effectively. So if you start typing in contraceptives, you can see that you actually have more options to you for treatment summaries than if you fully write out the word contraceptives, which is a little bit crazy to me. So you've got your intrauterine copper devices. So that's your copper coil that I've just talked about. You've then got contraceptives hormonal, non-hormonal, and you've got interactions as well. So that'd be really important when thinking about sort of medication review questions, prescription reviews. And then you've also got emergency contraception, which we'll touch on later. But those are all the treatment summaries that you want to get familiar with. Okay, so our first prescribing question. Just like the message in the chat once you've had a go, and we'll go through it.
We've got 5 likes. I don't know if you want to wait a little while longer, give people a chance.
Yeah, we'll give it maybe 1 more minute and then we'll keep going because there's lots to cover. Okay, perfect. We've got 10 responses. Okay. So one of the appropriate answers here, because there would be many, would be this version of the combined oral contraceptive pill. So 1 tablet, oral route once a day. Brand names that I've mentioned previously that I think will speed up answering this question would be Regevidon, Microgynon, Yasmin. If you just learn 1 or 2 of those, I think it goes a long way. And key sort of learning points for this would be if you're starting the combined pill within 5 days of the menstrual period, then it's safe to use that as your only form of contraception immediately. So you're protected from the point that you start. If you're commencing more than 5 days from your period, then you need to advise the patient to use additional precautions, so barrier method of contraception for the first 7 days, even while taking that pill. And counselling, again, it's important that they're taken around about the same time every day. Okay, let's move on. So we've got another practice question here, just once again, like the message in the chat and see how you get on. So there's a question in the chat saying, do you need to state specific doses because there's lots of different micrograms, and if so, which one? So no, you don't. It will be obvious on the PSA prescribing platform what dosing options are available to you in terms of the estrogen and the progesterone component. So there are a lot of different brands of contraceptive pill, and they all have slightly different amounts of hormone. So it doesn't particularly matter. The main thing here is that the combined pill was appropriate to prescribe in this patient. They didn't have any contraindications to that, so that's fine. And the slide that I showed just a little while ago with all the lots of different brand names, any one of those should have been fine for this patient. Hope that answers your question. Okay, I think we'll go through the answer now. So the answer here would be the progesterone only pill. So once again, I would just learn the name of this and get familiar with typing that into the BNF. And once again, it's the oral route once a day. And the key learning point here is that the combined pill is contraindicated within 6 weeks postpartum, and that's due to your increased risk of a VTE. There's also a note that it could reduce milk production, but the main risk here is increased risk of VTE within that postpartum period. So the progesterone only pill can be started a little bit earlier. So you still have to wait 3 weeks from giving birth, but it can be started from then. So in terms of how to find that on the BNF, so I would always check whether the contraception is appropriate in breastfeeding and if there's any time constraint on that. So there's a specific section on your drug to check for that when you're on the BNF. Okay. In terms of the progesterone pill, just generally, not necessarily in pregnancy, so it should be commenced on day 1 of your menstrual cycle, which is the first day of menstruation. And if administration is delayed by 3 hours or more, so you take it 3 hours later than you should have that day, then that's considered a missed pill and to be treated as such. So it has a much shorter window for you to take it effectively. Okay, so that was a little taste of contraception. Now move on to HRT, which I think people do find quite hard. So I've tried to come up with a little sort of checklist for how you might go about prescribing HRT for you. So the first thing I'd ask is, do they have a uterus? So if they don't have a uterus, then it's fine just to give estrogen, only estrogen. If they do have a uterus, so you need to be giving estrogen plus progesterone. And so in your question stem, look to see if they've had a hysterectomy for any reason. Look to see if they've had any abdominal surgery, because that might be a clue on how you're going to answer this. And in terms of why they need the progesterone, so having an unopposed estrogen source when you have that uterus present can predispose to endometrial hyperplasia, which then might increase your risk of endometrial cancer. So that's why the progesterone component is so important there. Your next question is, when was their last menstrual period? So if that last menstrual period was within 12 months, then they're going to require cyclical HRT. And what we mean by that is you have continuous estrogen through the month, but then you also have added progesterone to those tablets in the last 2 weeks of the cycle. Whereas if their last menstrual period was more than 12 months ago, so more than a year ago, or more than 2 years ago for a woman that has entered menopause prematurely, or they've been on cyclical HRT for a year already, then they can have continuous HRT. So that's where they have the estrogen and the progesterone the whole way through the month, and it doesn't change depending on what time of the month it is. And then the last bit is what's their preference for HRT? Some people will be happy to try a patch. Some people will prefer an oral tablet. And then if a woman has just got sort of localized symptoms of vaginal atrophy and dryness, maybe some dysuria, then and no sort of vasomotor symptoms like flushing or night sweats or something like that, then you might just be fine prescribing sort of a topical estrogen preparation, so just a topical sort of vaginal gel or something like that. It might be more appropriate. And also being aware that if a woman does require the progesterone component of HRT, then that can be given via the intrauterine system that we've already talked about in the context of contraception. So that can be given by you might have heard it called the Mirena coil. So that's your hormonal coil, okay? And I think a key learning point is that generally transdermal is the preferred route because it has less of an effect on clotting factors and so possibly less of a VTE risk. So that's a key takeaway there. Okay, so this is a prescribing practice. Just have a go and we'll talk it through. Okay. Things to signpost to. So the sex hormones treatment summary on the BNF would be the most helpful here. There's a picture of it at the bottom there. And once again, I'll probably recommend learning some HRT sort of constituents so that you can just search it up and it'll save time in the PSA. But give it a go and just like the message when you're done.
We've got 6 likes. Might wait for a couple more.
Yeah, that's really good. It's not the easiest question. That's great, guys.
Yeah.
Thanks for responding on the chat. You're being brilliant. Okay. Before we explain this question, just a quick note. So here I did mention, so if their last menstrual period, it has to be, and this is a lady in premature menopause, their last menstrual period had to be 2 years ago. So for those of you unsure, so premature menopause is before the age of 45. That's probably a useful fact to be aware of for this. Okay, so let's look at the answer for this question. So going through the question, so got a 53-year-old woman. She's previously trialed patches, but she would really like an oral prescription of HRT. Her last menstrual period was 4 years ago, and her uterus is intact. In terms of her past medical history, she's got some Barrett's esophagus, high cholesterol, and some asthma. So we already know that this lady still has her uterus, so she needs the progesterone as well as the estrogen. And we know that her last menstrual period was over a year ago, because she's 53 years old. So over a year ago is ample time to give the continuous prescription rather than the cyclical one. And if this lady was younger, if she was 41, say, and she'd entered premature menopause, then I would be checking to see that her last menstrual period was over 2 years ago to be able to give that continuous HRT preparation. So that's sort of how we've got to the answer here. I've chosen a Lest Duet Conti 1 tablet, which is just one of the many things you could have prescribed. On the BNF prescribing guidance, it says to be started at the end of a bleed, especially if changing from cyclical HRT. But in terms of breaking this down, HRT is prescribed by brand name. This duet section of the name tells me that it's got estrogen and progesterone in it, so it's got both. And Conti symbolises that it's a continuous prescription. So the way that the brands are named kind of tells you what it is, but you're going to have to build up some familiarity with these things over time. So I learned 2 brand names. So I learned estradiol with norethisterone. So that comes in an oral HRT preparation and a patch. And then the estradiol with levonorgestrel just comes in the patch form. And I think that really speeds things up. You can look them up under the treatment summaries, but I think this is a lot smoother. And just to demonstrate what I meant about the naming of the brands, so this is just a screenshot from the BNF. I think all I typed in to get this up was Everel or Alesti. I'm not exactly sure how you say it. But basically, so this top one, I think it's what I prescribed actually. Yeah, so the top one here on the top left-hand side. So that's showing the cyclical HRT prescription. So you've got 1 tablet for 16 days, and that will just be the estrogen. And then you've got a different tablet for the next 12 days, and that'll be the estrogen plus progesterone. So that's how you know it's that type of HRT. And then if we go to the bottom left-hand corner, you can see that's the one that I prescribed. So that's the continuous form containing both hormones for the whole time. So it's just 1 tablet continuously. I hope that makes sense, the difference there. And then the top right hand and the top left hand corner of the screen, that's just a different brand name for much the same thing. So at the top of the screen there, you have the continuous version, and at the bottom you have the cyclical version with the 2 different hormones at different times of the month. So hopefully that sheds some light on the different brand names, because they are quite tricky. Okay, so swiftly moving on to emergency contraception. So once again, I like to think of this as first, second, and third line, and that's how I broke it up in my mind. So the first line would be the copper intrauterine device. So that's the most effective form of emergency contraception, and would be recommended first line, but not everyone would like an intrauterine device as emergency contraception, which is understandable. So with this one, you can use it up to 5 days after unprotected sexual intercourse, or after the earliest date of ovulation. So when you think ovulation might have occurred, and that would be around day 14 of the menstrual cycle. So I'd say the copper IUD is really more appropriate, especially if a woman is taking enzyme-inducing drugs. So any drugs that might interact with hormonal contraception in any way, and I do have a slide on this later on. The benefit of this one as well is that you're going to be provided with ongoing contraception from the moment that IUD is fitted. So that can be preferable for some women. And I think I've sort of mentioned this before, but an STI screen might be appropriate depending on the risk profile, and so antibacterial covers sometimes given. So that's the copper IUD. And then the next most effective option would be what we call ELA1, and the drug constituent in that would be ulipristal acetate. And that one can be used up to 5 days, again, after unprotected sexual intercourse. And it can be used more than once within the same menstrual cycle, which is quite important to know. However, you can't initiate hormonal contraception after this, so like your regular combined pill, for 5 days. So if you do have ELA1, you can't start hormonal contraception for 5 days. And there are some important contraindications for this one. So severe asthma that's controlled by oral steroids would be a contraindication. And any gynecological malignancy or something I've mentioned earlier, if you have unexplained vaginal bleeding, then it's not really appropriate to be prescribing these hormonal forms of contraception or HRT, because that estrogen component or progesterone component with whatever might make it worse, may mask symptoms. So that's our second option. And then we also have Levenel, which is the brand name for levonorgestrel. So another option, but with a shorter time period. So that one would have to be used within 3 days of the unprotected sexual intercourse. And something really sneaky about the prescribing with this one is if you have a lady with a higher BMI, so more than 26, or if they weigh more than 70 kilograms, then they're going to require double the regular dose. So that might be something to look out for in a question. But this one is appropriate in women who are breastfeeding. And it's appropriate for women who want to quick start onto hormonal contraception. So unlike ELA1, you can start your hormonal contraception immediately after having this. So that could definitely be an advantage for some women there. In terms of contraindications for Levenel on the BNF, it says current breast cancer, and that makes sense with the hormonal component. So one thing to try and wrap your head around is that with emergency contraception, if it's the hormonal forms, so the ELA1 or the Levenel, it's not going to be effective if ovulation's already occurred. So the way that these work is they work by inhibiting ovulation. So if that's already happened, then they're not particularly effective. So then you would want your copper IUD as a more appropriate option there. Little note at the bottom here. So emergency contraception should be offered from day 21 after childbirth. So that's 3 weeks, like we've talked about previously. And from day 5 after ectopic pregnancies, miscarriages and abortions. So there are things that you might not necessarily think about, but you should also be offering emergency contraception in this scenario. Okay. In terms of the treatment summary, it's called emergency contraception, so it's quite easy to find for this one. Okay, so another question, give it a go and like the message and we'll go through it. we've got some questions on the chat here. So one question, so is it the oral glucocorticoids that make a contraindication? If someone was taking oral glucocorticoids for another indication, not asthma, would that be a contraindication? That's a really good question. I think the issue is that
I'm just working on an answer, sorry, in the chat as well.
Oh, you are? Okay. I think it's, am I right in thinking that it makes the glucocorticoids less effective? And so
Yeah,
your
so
asthma would be
there's
poorly managed.
exactly. So there's an increased risk of asthma exacerbations.
Yeah, exactly. So I think it would be something to bear in mind with lots of conditions that would be managed with glucocorticoids. So that makes sense if it makes them less effective. But specifically, asthma is a contraindication with the use of glucocorticoids, because it's obviously pretty dangerous if your management suddenly drops off. Hope that answers your question. So if another question is, if they have ELA1, can they be active for the next 5 days without any protection? I would suggest not. If ELA1's inhibited ovulation and they were sexually active again without protection, they might be protected, but it's important to remember that sperm can live in the reproductive tract for a number of days. I think it's about 5 days. So I wouldn't advise that if that was a question from one of my patients. I hope that makes sense.
We've got 9 likes.
Okay, that's great. Right. Okay, so let's go through this one. Okay, so here I've prescribed ulipristal acetate. So just go through the question. So we've got a 26-year-old lady, sexual health clinic, emergency contraception. So the unprotected sexual intercourse was 72 hours ago. So we're getting on for quite a few days now. Her last menstrual period began 8 days ago. Now, the reason that's important is what we've discussed. So it's unlikely that she would have ovulated yet. So ovulation's around day 14. Her menstrual cycle is regular. It's 28 days on average. She's not got any regular contraception. Her urine pregnancy testing clinic is negative. Now, that's important if you were thinking of prescribing the IUD or fitting the IUD. She's not breastfeeding, no regular medication. And in terms of her height and weight, she's over 70 kilograms, which is the important weight here. And they're opposed to having an IUD. So the patient preference, she does not want the copper coil. So going through this, so the BMI is high and they weigh more than 70. And that's why you either want to go with the ulipristal acetate or the double dose of levonorgestrel. In terms of why you can't do the double dose of that one, it's because they're over the 3-day limit. So that's why you're stuck with ELA1. And the copper IUD, although that's, like we've discussed, the most effective, it goes against the patient wishes. So that one's inappropriate. So that's how we got to that answer. Okay. So just drilling it in once again. So undiagnosed vaginal bleeding is a contraindication to prescribing hormonal emergency contraception. Okay, so really important to be aware of that. All right, so just skipping to another prescribing practice question now. Give it a go and like the message. This one's a little bit different. I've just seen Sarah's question. So what would you advise someone to do in the meantime if they can't start contraceptive pills for 5 days? So yes, you'd advise them to use barrier methods of contraception in that period. And then probably best practice would be booking them into a contraceptive clinic to discuss all the options available to them and what would be best going forward. Oh, sorry, Mosey answered it already. Sorry.
No worries.
Sorry, I just went off there.
You're doing a very good job with the questions.
Yeah. Okay, I think I'm going to go through it just because we don't want this to go on too long. People have got things to do, I'm sure.
We've got a good 10 likes.
Yeah, there we go. That's amazing, guys. Anyway, you guys are doing so well with this. Okay, so this one's about incontinence, kind of comes under women's health. Very common after childbirth, I hear. So let's talk about it. So we've got this 68-year-old lady. So she's got urgency, some frequency, and urging incontinence. It's just for this patient, you probably do. Well, if she had any dysuria, you might want to consider doing urine MCNS, sending that to the lab. You wouldn't want to miss a UTI. Does anyone know why I wouldn't dip this lady's urine? Can anyone pop that on the chat just as an extra? Have a think and see if you can let us all know. Current medications, so lisinopril, timolol eye drops, Senna. So we know that she's constipated, she's got some glaucoma, some hypertension, and we want some treatment for her incontinence. So here we've gone with mirabegron. And the reason being, so I like to think of the two main types of incontinence. So you've got your urge incontinence, which is what this lady appears to have, and stress incontinence as well. So stress is more commonly if you're coughing, if you're straining, if you're running, and you might have some leakage of urine. Whereas urge incontinence is that you have the sudden urge to urinate and you can't get to the toilet in time. You can also have mixed incontinence, where you have features of both, but usually in mixed incontinence, you've got sort of a set of features that's more prevalent. So the stress incontinence part might be a little more prevalent, and so you go with treating that first. But just for the sake of sort of the PSA and getting confident with this, we're going to think of the two main types. Now, with urge incontinence, the first line therapy is bladder training. And that's for 6 weeks. But it says in the question stem that she's already tried bladder training and it's had limited benefit. So we're going to move on to second line. Now we've got antimuscarinics, so oxybutynin's one of them. We've also got mirabegron here, which is what I've prescribed. Now, the reason I think antimuscarinics are less appropriate is because this lady has glaucoma. So it can make that worse. She's also got constipation, so it's going to probably exacerbate the constipation. And generally in sort of older people, I mean, this lady's not really old, but she's likely to be more frail and she's on the older side. And I think you want to be cautious of using antimuscarinics in this patient group. So that's why this is the more appropriate option here. And then third line, if that still wasn't all that helpful, then specialist referral, the Botox, and then stress incontinence. So the first line for that's pelvic floor training. This is a little bit different and that lasts longer, so that's for 3 months. And then the medication of choice for stress incontinence would be duloxetine. And then once again, third line is specialist referral there. So just a quick sort of overview of that one for you. Okay. So now nausea and vomiting in pregnancy. So mild to moderate nausea and vomiting is quite common and it usually resolves by 20 weeks. However, if the symptoms do persist, despite sort of self-care advice, that's, drinking peppermint tea, small meals often, small sips of water. So if you're still nauseous after that, then the first line would be oral cyclozine or promethazine. You can always also use prochlorperazine or chlorpromazine. And then second line, so would be your dopamine receptor antagonists. So you might have heard of metoclopramide or domperidone. And then ondansetron would also be a second line. But it's really important to be aware of some of the side effects of these. So with your metoclopramide, it can cause extrapyramidal side effects, which we would have gone over in the psychiatry teaching that Mosey did. So could be sort of Parkinson's-like symptoms. You can have acute dystonias where your muscles seize up. So that can be something to be aware of there. With domperidone, there's a risk of cardiac adverse effects. And ondansetron specifically, if a pregnant lady is prescribed ondansetron, you need to be counselling about the risk of cleft lip or cleft palate. So it's a small increased risk, but that would be something key to mention to the pregnant person. And then third line would be a course of oral steroids. Of course, this whole slide is assuming that they can take medication orally, and some people will need admission to hospital for nausea and vomiting in pregnancy to be rehydrated and receive antiemetics through a cannula. Okay. So other things to just have in your mind in this kind of situation is, are they constipated and is that making it worse? Because then laxatives are really helpful in a lot of patients that are just feeling a bit nauseous, regardless of if they're pregnant. Do they need VTE prescribed? So obviously higher risk in pregnancy, and if you're dehydrated as well, higher risk. And then thiamine as well, if they're really struggling with other dietary intake. And just on this slide, we don't have to go through all of them now, but there's just some criteria of when you might be considering referring someone into hospital with severe nausea and vomiting in pregnancy. And that would be sort of clinical dehydration, loss of body weight, and there's something called a puke score as well. So that's easy to remember for this. Okay, so let's keep going. So prescribing practice for this. So the treatment summary I recommend is nausea and labyrinth disorders, and there should be a section on pregnancy within that, if I remember correctly. So give it a go and just like the message when you're done. Yeah, so just some answers to my question on the chat. Why would you not urine dip someone over 65? Is because they're likely to have bacteria in that urine and to be asymptomatic. So asymptomatic bacteriuria is just clinically not all that relevant and shouldn't particularly guide you prescribing antibiotics. Yeah, the other questions have been answered as well, but you could give mirabegron 50 as well. That's just me giving a very small dose. But you're right, in the BNF it does say 50, so that's fine. Yeah, topical estrogen for urge incontinence might be appropriate as well. You could certainly trial that, but I don't think it's sort of within the NICE treatments guidance as a first line, but very well may be helpful. Oh, we've got loads of answers already.
Yeah.
So I'm just talking to myself. Okay, nausea and vomiting in pregnancy. So here I prescribe cyclizine. There are lots of different options that you could prescribe here, referring back to the previous slide and the BNF. So don't worry if you didn't pick that. But just why maybe that's more appropriate than some others I've mentioned. So ondansetron second line, and there's the small risk of cleft lip and palate, metoclopramide, risk of EPSCs, and dexamethasone, that's way down the treatment algorithm, so third line, and for sort of refractory cases only. So let's move on. All right. Okay, so we've got prescription review now. These do take a little bit longer. Don't worry if you don't get through the whole thing. You'll have access to these slides when you fill out the feedback, okay? So just give it a go and like the message. Okay, so we'll go through this one now. All right. So the 3 prescriptions that are inappropriate, so ibuprofen, ramipril, and dapagliflozin. So ibuprofen is less appropriate in pregnancy. I think it still can be given in the right circumstances, but it could lead to premature closure of the foramen ovale, so within the baby's heart, and ramipril, so ACE inhibitors, ARBs are not recommended in pregnancy. And dapagliflozin, so one of your diabetes medications, so it's usually metformin is acceptable or insulin, not the other anti-diabetic drugs. And one prescription requiring some adjustment would be the folic acid. So the dose prescribed is the standard dose of folic acid, but this lady seems to have a comorbidity that means she would require the higher dose of folic acid, so that'd be 5 milligrams. So just a little bit about folic acid quickly. So it's taken from 3 months prior to conception until week 12 of pregnancy, and it's to reduce the risk of neural tube defects within the baby. And indications for that higher dose of folic acid would be maternal or paternal history of a neural tube defect, a prior pregnancy where the child's affected by a neural tube defect, diabetes mellitus, which is what's the case in this question. So we know this lady's on metformin and dapagliflozin, so we infer that she has diabetes. If the mother's taking anti-epileptics as well and antiretrovirals. So I hope that makes sense. So here's just a quick high yield slide. So some unsafe drugs in pregnancy. Now I got this information from the BUMPS website, which is a really good website for checking medications in pregnancy and breastfeeding. So it's not something you'd have access to during your PSA, but for revision purposes and gaining awareness, I definitely recommend it. So we've talked about NSAIDs. Early closure of the ductus arteriosus is what I meant, sorry, not the foramen ovale. So ACE inhibitors as well. So there's a risk of kidney problems and not having enough amniotic fluid. Same with Ang2 receptor blockers, so losartan. And then another one to be aware of in pregnancy is definitely the oral retinoids, so isotretinoin that's used for acne. So that can cause quite severe defects within an unborn child. So they're listed just on the slide here. And then warfarin as well. So that's been linked to an increased risk of miscarriage. So these are all medications that we wouldn't recommend during pregnancy and probably quite common ones to be aware of. Warfarin, not so much anymore, I don't think, within the younger population, but could definitely come up in a question. And these are some other drugs that just came to mind that I also think are maybe a bit more common, especially sort of lithium for patients with bipolar, doxycycline, that could be a sneaky one in a question as well. So if possible, all teratogenic drugs should be avoided within the first trimester, as that's when the developing fetus is the most vulnerable. Okay, so another prescription review question. Give it a go. I know these do take a bit longer, and just like the message when you're done. And yeah, you still get marks on these questions, even if you don't get all 3 answers. So if you only got, say, 1 or 2 of the drugs that are inappropriate, you'd still be marked for that in the PSA, because the way it works on the platform is there are little check boxes. So you check each one off and you're not negatively marked, which is important as well. Charlotte, I don't know if you are listening in right now.
Hello.
It might be a good idea to put the feedback form on the chat, because I'm aware that
Yeah, I'm so
we've
silly.
already been an hour.
I
and
usually do that. You're so good. I forgot.
you know, some people might just want to head off and look at it when they are more refreshed.
Lovely stuff. I think we maybe nearly reached enough responses to release second recording, but last time I checked, it was like 110 people had watched, and we were just about hitting 30 responses. So
Oh,
yeah,
that's the same, isn't it?
I mean, the people who come to these sessions, they get the goods.
I know.
The non-responders to the feedback form, they can wait.
The feedback is so important because it highlights things that we can tighten up, highlights things that we didn't cover.
Yeah, we got some really good feedback last week about insulin dosing, which we'll talk about at the end, actually, just as a public service announcement.
Yeah, that's a good idea. Okay. We'll give it just a couple more minutes. I know that we're getting on for time a little bit, but there's so much to this session.
I think sometimes we even used to go to 8:30, so usually you're kind of in the similar lane to what we've done before.
That's good. I'm so aware that brains do flag towards the end of the day, including mine, at times. Okay, let's go through it, and then people can follow along, and you'll get access to these slides, so don't worry. Okay, so 4 errors in the drug chart. So I don't know why it says A, B, C. Sorry about that. It's just supposed to be A and B. So microgynon will be contraindicated in this patient because they've got a migraine with aura. Okay, so if you've got migraine with aura, increased risk of stroke when you're on the combined pill. Secondly, they've recently had a stroke, so enoxaparin might not be the most appropriate, given that they might have had a recent cerebral hemorrhage. That's going to put you at high risk of bleeding. In terms of bisoprolol, that's not the correct dose. So 200 grams of bisoprolol is very high. So that's an error there, which hopefully you would have picked up on. And then Novamix, so the insulin is the incorrect route. So it should be subcutaneous rather than IV. So hopefully that makes sense. In terms of the 2 drug interactions, so we've got bisoprolol and verapamil here. And this is a common question that I've seen quite a lot. And so you shouldn't have beta blockers being used with rate limiting calcium channel blockers. So your verapamil and diltiazem. So they're your rate limiting calcium channel blockers. And it's unsafe with a beta blocker because it can precipitate a complete heart block. And then the other interaction is microgynon. So your combined pill, that's just the brand name, and St. John's wort. So that's a herbal remedy that you can get over the counter, and is known to decrease the efficacy of the combined pill. And I think St. John's wort is quite a common one to spot, that causes many different interactions. Okay, so some high yield info. I think I mentioned this at the beginning. So certain drugs that might interact with the combined pill. So carbamazepine, anti-epileptic. So it induces hepatic enzymes. So enzyme inducers will make the combined pill less effective. Also got phenytoin. I think that's less common to see, but once again interacts. You've got rifampicin as well. St. John's wort we've talked about. They've got orlistat as well. I hadn't heard of this while I was making the slides, but it can decrease the absorption of the contraceptive, which I thought was quite interesting. Probably a little bit less likely to come up, but there you go. Okay, we've also got more liver enzyme inducing drugs. I've put in bold the ones that I think I've seen more in practice questions. So rifampicin, carbamazepine, like I mentioned, St. John's Wort mentioned, and then your protease inhibitors, so your antiretrovirals, I think could come up, and a lot of them end in vir, so they're quite easy to spot if they're on your radar. But contraception that wouldn't be affected by the enzyme inducer, so it'd be your copper intrauterine device, your intrauterine system as well, and then your progesterone injectable. So remember, not all forms will be impacted by these. Okay, so I have a planning management question here. Give it a read and like the message when you're done. Okay, we've got some good responses so far. Great. Okay, fab. Let's go through it. Right. So for this lady, nitrofurantoin for a UTI for 7 days whilst awaiting culture results. So she's a pregnant lady. She's got your classic UTI symptoms. She's not got a fever or flank pains. We think is less likely to be pyelonephritis. Urine dipstick's positive. We've not got culture results yet. Okay, so UTIs in pregnancy should be treated even if they're asymptomatic. So this lady does have symptoms, but if this was just found on a urine dip, you'd still treat. And you shouldn't delay starting antibiotics while awaiting the culture results. Instead of the usual 3-day course for a UTI, you're going to give 7 days in pregnancy. And a little note about the antibiotics. So nitrofurantoin is recommended, but you should avoid it at term or close to term because there's a risk of neonatal hemolysis. And then trimethoprim, so that one can be used closer to term, but should not be used in the first trimester because there's a neural tube defect risk. And then ciprofloxacin is thought to affect the cartilage development. So just shows something that you're probably very comfortable prescribing for a UTI, but it is different in pregnancy. And then for this treatment summary, it's the urinary tract infections, and there's a specific section on pregnancy that you should be able to see. It's called Pregnant Females. It looks like this. So first line is nitrofurantoin, but then if you click into the nitrofurantoin page and you go to the pregnancy section, that's where you'll see avoid at term may produce neonatal hemolysis. So it's always worth checking the pregnancy and breastfeeding sections, even if it's recommended within the treatment summary for the pregnant females. It's just an example of that you want to be checking both in the PSA. Okay, another planning management question. Give it a go and like the message. Okay, we're doing well. Let's go through it. Let's keep up the pace, guys. All right. So the answer here would be stop warfarin and switch to low molecular weight heparin. So this lady has a history of VTE. She's been taking warfarin. I do think this is a little bit unlikely. I don't see many young patients on warfarin, but there you go. It's for practice. And which of the following is the most appropriate management plan? So warfarin's not appropriate in pregnancy. So we sort of mentioned that already. It's teratogenic, particularly in the early gestation. And there's something called fetal warfarin syndrome, which will have this specific set of abnormalities. So you'd want to stop warfarin, and then the low molecular weight heparin is safe and effective in pregnancy, so both for prophylaxis and for treatment of VTE. And a little practical tip is that low molecular weight heparin is prescribed based on weight. Okay, so where did I get this information? So venous thromboembolism treatment summary on the BNF, and there should be a section for pregnancy there as well. Okay, so quick overview of planning management. So UTIs, we've already touched on it, but first line is nitrofurantoin. That's the one you avoid in the 3rd trimester. And then second line, you've also got amoxicillin listed or cefalexin. Really important to review if there's no improvement within 2 days. Okay. Anticoagulation in pregnancy. So low molecular weight heparin is appropriate in pregnancy. And you want to restart it 4 to 8 hours after birth and continue for 7 days after birth. Okay. And then in terms of pain management in pregnancy, so this isn't intraoperative pain management that we're touching on. This is just sort of general pain while you're pregnant. So non-pharmacological options would be recommended first line. Paracetamol is safe, so it doesn't increase the risk of major birth defects. And as I mentioned earlier, NSAIDs are probably not ideal, but they might be required if the pain is sort of unrelenting, and NSAIDs are more appropriate for some types of pain than others. Okay. All right. So this is just talking about the venous thromboembolism treatment in pregnancy. So that's the specific section of that treatment summary. And just to show you that VT is, or enoxaparin is dosed by weight. So that could be a prescribing question for you right there. With low molecular weight heparin, I would learn a brand name as well. Like I'm comfortable with enoxaparin, but you could do Clexane or something like that. It will speed you up in the exam as well. Okay. All right, more planning management. So diabetes in pregnancy. So metformin can be used, insulin can be used, and that would be the main takeaway there. If you don't know the testing for gestational diabetes, if the woman has a fasting glucose of above 7, then they just go straight on to insulin. Okay. So hypertension in pregnancy. So ACE inhibitors and ARBs, not recommended. Labetalol is, but remember that's contraindicated in asthma. Nifedipine is also an option, but with nifedipine you have to be careful if there's a history of angina or myocardial infarction, and then methyl-dopa is a 3rd line as well. But so with hypertension in pregnancy, always check in the question stem. Do they have any underlying physical health conditions like asthma or angina? Okay. So preeclampsia. So be aware of your common symptoms of preeclampsia, so headache, visual disturbances, edema, and a high blood pressure, and then protein in the urine, because you want to be able to spot that in the question stem. And IV magnesium sulfate is what would be given in preeclampsia. And then put exposure to varicella zoster virus, because I think this is a tricky one if it were to come up. So just some general tips. If a pregnant person's been exposed, then they'll need a blood test to see whether they have immunity or not. And if they're not immune, that might be when you give antivirals or varicella zoster immunoglobulin for them. It's a little bit more niche, but who knows, might come up. So hypertension in pregnancy, there's a specific part of the BNF for this under your hypertension treatment summary, to alert you to the fact that you can have hypertension diagnosed before pregnancy, you can have pregnancy-induced hypertension, and you can have preeclampsia, and they're all slightly different. It's just being aware of those 3 classes. Okay, so drug counselling. So this is advice on the combined pill. So hopefully this one will be a little bit quicker and like the message when you're done.
We've got a few likes going.
Fab. Let's go for it then. I think this is harder to find on the BNF anyway. Okay, so the patient missed 2 pills within the first week of their pack, and they had unprotected sexual intercourse within that time. So emergency contraception is indicated. So you should consider that emergency contraception if the missed pills occurred within the first week of starting the pack. Okay, so that's the key bit there. You're advised to take the missed pill as soon as possible, and avoid sexual intercourse or use a barrier method of contraception for 7 days until 7 consecutive pills have been taken and you've re-established that protection there. Okay, so this is a great resource that I'd like to signpost you guys to. So it's the FSRH guidance on missed oral contraception. I think it's one of the most clear resources. So that's where this is from. And it just gives the time frames and whether it's 1 missed pill or 2 missed pills. So really, you should be protected if you just miss 1 pill. It's when you've missed 2 that you need to take some action usually. Okay. So here, the top bit of the diagram, 2 to 7 pills missed in week 1 after the hormone-free interval. That's what HFI means. Consider emergency contraception if UPSI has taken place during the HFI or week 1. So that's sort of where I got the answer to that question from. And having an awareness of this, I would say, is really, really helpful. Okay, so drug counselling. Just like the message when you're done. We are getting through it. I know there's a lot to this session. Okay, fab. Let's just go through it. The responses are coming in. Okay, answers B. Blood pressure is really important when you're on the pill, and that's the takeaway. Okay, so a little bit of sort of key points to take away here. So contraindications, also not the pill, HRT, my mistake. So contraindications for HRT, so we're going to be breast cancer, current or past breast cancer, endometrial cancer, current or past, the unexplained vaginal bleeding, which we talked about, history of VT or stroke, severe liver disease, and untreated hypertension. So that's what's key here. And although obviously made a bit of a mistake there, this question is about HRT, not the combined pill. Hypertension monitoring is really important for the combined pill as well. Okay, so that's something to keep in your mind for both. Key counselling information for HRT. So there is an increased VTE risk, there's an increased stroke risk, slightly increased breast cancer risk. If you get unopposed estrogen in HRT, like we've talked about, then it can increase your risk of endometrial cancer. There's a slight increased risk of gallstones as well. But with all of these, the risk can be minimized if you take the transdermal route over the oral route. Okay, fine. So drug counselling. So folic acid in pregnancy. So we're just sort of repeating what we've done earlier a bit. So the 400 micrograms is the usual dose. The 5 milligrams is the higher dose for those people with risk factors and certain medical comorbidities like diabetes. And one thing is that folic acid should never be given alone in a megaloblastic anemia. And you've probably heard this from doing your revision for finals, but it can precipitate subacute combined degeneration of the cord. So I always like to remember it like the alphabet. So B comes before F in the alphabet. So you always give B12 before folate. That makes sense. And then hormonal emergency contraception good counselling advice is that if vomiting occurs within 3 hours of taking the emergency contraception, then you need to have a replacement dose because it probably wouldn't have been absorbed. Okay, and any abdominal pain in someone that's taken emergency contraception or even has a coil fitted, always have ectopic pregnancy in the back of your mind for that one. Okay, fine. So adverse drug reaction, like the message when you've given it a go. I think we only have about 5 slides left, guys, so you're doing really, really well. Okay, let's go through it. Fab. Answers D. So migraine with aura. So usually if someone has a history of this, you wouldn't prescribe the pill, but people can have worsening migraines or a development of an aura with their migraine once they start the pill. And that's a contraindication because of increased risk of ischemic stroke, which I think we've already touched on. Okay. The other side effects, they can be quite common, but they wouldn't usually require you to stop the medication because they're a bit less serious. Okay. Fine. Adverse drug reactions. So we've got the combined pill and HRT here. So there's a lot of crossover between the adverse drug reactions. And I would say the ones that confused me a little bit when I was revising were the increased risk of cancers. So the breast cancer risk returns to baseline within 10 years of discontinuing the combined pill. But with HRT, this risk of breast cancer persists longer. It doesn't sort of go down quite as quickly. And then you've also got an increased risk of cervical cancer with use of the combined pill. And you get that increased risk after 5 years of use of the combined pill. There's also some mood sort of side effects to be aware of with the combined pill, but there's no evidence that it causes weight gain or loss of libido there. So hopefully that's a good summary for you. I'll move on because of time. And we'll do some drug monitoring now. So just like the message once you've given it a go. Great. Fab. Thanks, guys. Any more? Okay, fab. That's wonderful. All right. Okay, so blood pressure. I sort of alluded to the answer just a few slides ago. So blood pressure is really important for combined pill monitoring, and uncontrolled blood pressure would be a contraindication. One of the little sort of learning points here is that the patient is on topiramate, and this is a hepatic enzyme inducer. So that was a bit sneaky here. It wasn't part of the question, but that I just advise you to keep questioning what medications the patients are prescribed in these questions, because these question stems are written to test you. And here this patient might need additional contraception because it might reduce the effectiveness of the combined pill. So just to put that on your radar. Okay, so we've got a data interpretation question here. I think there's only one of these, so give it a go and just like the message. Okay, let's have a look. Okay, so the answer here, I've put cephalexin or trimethoprim. So I think this question is quite reflective of clinical practice, to be honest, and how sometimes it's not all that clear. So amoxicillin would be the second line in the BNF for UTI in pregnancy, but this patient does have an allergy to piperacillin and tazobactam, and that obviously contains a penicillin, so that would not be too appropriate. In terms of gentamicin, so the sensitivity results, yeah, it's sensitive to gentamicin, but that's given IV and it's more appropriate for sort of very unwell patients with urosepsis, and it has quite a narrow therapeutic index, so you'd need gentamicin monitoring level, and that would determine your next gentamicin dosing. So it's less appropriate in this scenario. As this lady's not admitted to hospital, she's just gone to the early pregnancy assessment unit. So nitrofurantoin would be inappropriate because the culture shows resistance to this. Trimethoprim, it could be a suitable option, but it's not sort of listed as a key recommendation for UTI in pregnancy. And then cephalexin, so second line in the BNF for UTI in pregnancy, but there's the potential for some cross-reactivity with a patient with a penicillin allergy. I think it's unlikely and it's low, but I suppose that is something to be aware of. So that's why I've put cephalexin or trimethoprim as options. But as a practical tip for you guys who are going to be going into F1 soon, I would recommend discussing this with a senior, this type of situation, and calling microbiology for guidance, because they are really helpful. And the more information you put on a microbiology request form, so on a urine culture form, the more clinical information you can put on that, the more helpful microbiology tend to be, because they understand the clinical situation much better. So that's just a little practical tip there for you guys. Okay, so this is just illustrating how to use the BNF once again and getting you guys comfortable with that. So we've seen this treatment summary before. Nitro, the bacteria is resistant to that. So we have amoxicillin, but we know there's a history of penicillin allergy. And if you click on amoxicillin, it says for all penicillins, history of allergy is a caution. And then for cephalexin, under allergy and cross-sensitivity, the only one that's listed there is contraindicated in patients with cephalosporin hypersensitivity, which our patient doesn't have. So I think that could be an appropriate option to prescribe here. But alternative second line, which may be the trimethoprim, consult local microbiologist. So that's sort of how this would work practically for you, maybe. Okay, so another data interpretation question. Give this one a go. I think this is the last one. I think these data interpretation questions are a little bit more wordy, and that's something I found in the PSA last year, that the question stems were a lot longer than I was expecting, and it just pushed me from a time perspective. So I say really, really time your practice when you're getting closer to the exam. Okay, we've got lots of answers, that's great. Okay, so here I put B, so transdermal combination of HRT. And that's like we've talked about, that transdermal is preferable if you're worried about any of the side effects of HRT. So it will bypass the liver, and it's considered safer if there's some mild liver dysfunction. Because I think you'll find that non-alcoholic fatty liver disease is quite common in the demographic that would be requiring HRT. So this is probably quite a relevant question, hopefully. That should make sense. Okay, so we've got 2 more questions here for the whole thing. We've got calculation skills questions, and I think I'm going to skip those, given that it's written out step by step. The explanation's written out how I would calculate it. So hopefully that's easy to follow if you want to have a look at that in your own time. The 2 examples were calculating oxytocin infusion, which I think would be very harsh, and also some local anaesthetic as well. So if anyone wants to stay behind and we go through them, I'm very happy to, but I'm aware that we've gone a little bit over time now. So hopefully you can see the feedback form QR code there, and I think Charlotte will probably repost it in the chat just as I was saying it. Thank you, Charlotte. So if you could provide any feedback, anything that was good so that we can do that again next time, anything that was missing or you felt wasn't quite right, then we can address that. So please do tell us, okay?
You've got interest in the questions from one person.
Fine. I hope you didn't see the answers. Let's go back to the questions. Let's have a quick go at them. So,
thanks for coming, everyone. I'll record this bit as well, and then those of you that have come to the sessions before, you can just access the recordings in the Teams chat. It's just people who never come that I gatekeep.
So, this is the first one. For you, just send me a message when you'd like me to go through it, because I'm not too sure. I'm not sure how long this will take. Or just like the message, yeah. Perfect. Okay, fab. We've got a like. Okay, let's have a look. Fine. So this is talking about an oxytocin infusion. So that's going to be to augment contractions in labour. And really, this is not too much about why you need the infusion, but the calculation. So we've been asked for an infusion at 6 milliunits per minute, which I think is a relatively standard dose, but this is just an example question, okay, guys? So one thing that's key here is that we've been asked for the rate in milliliters per hour. So that might be what trips us up in this question, okay? So we've been given 10 units of oxytocin in 500 mils. So we've converted that to 10,000 milliunits in 500 mils, okay? And then what I've tried to do is work out how many milliunits we have in 1 mil. So we've done 10,000 divided by 500, and that gives me 20 milliunits in 1 mil. So we know that the answer is required in mils per hour, but we were initially given that infusion as per minute. So I've done 6 per minute is 360 per hour, okay? So then I've done 360 divided by that 20 that we calculated. That gives me 18. I think there are quite a few steps to that, and these do take time. I really found the calculation questions in the PSA took me a fair bit of time at least, okay? So move on to the last one. This is the very last question. So just pop in the chat when you're ready. Okay, we've got 2 likes. That's fab, guys. I'm very impressed with you guys still going with these practice questions. Okay, let's have a look. All right, so we've got a lady with a 2nd-degree perineal tear following vaginal delivery. Would like to repair the tear under local anaesthetic. Got 1% lidocaine without adrenaline. And this is the hospital guidance. So the max dose is 3 milligrams per kilogram. The patient weighs 71 kilograms. And we know that 1% lidocaine is 10 milligrams per milliliters. So we're asked for the maximum volume that she can be given. So first of all, I just want to find out the maximum milligrams that she can be given. So I've done 3 times her weight, which is 213. That's her maximum milligrams. And we know that we've got 10 milligrams per 1 mil. So I'm going to do the 213 that I've calculated divided by 10, and that gives me the 21 milliliters. So that's converting our milligrams to milliliters. Okay, that's the max milliliters that we could use for her. Hope that makes sense. And that is actually it now, so well done. How can we access the recording? Sorry for so many questions. Don't apologise at all. I think Charlotte's probably best. Thanks. Thank you.
Yeah, if you attend the previous sessions, you are in the team, so you get all of the recordings whenever we teach. And I've seen that people have been actually recording, like said that they've watched the recording, but it's for like session 2 and session 3. So it means people haven't even responded about session 1. So I'm not releasing session 2, but all of you can have it. No problems.
Yeah. So we really appreciate you attending and taking the time. And we're very happy to help out as much as we can. Any questions, just send them through.